Hi, I'm Wesley Walker of the New York Jets, former All-Pro wide receiver. You're watching Bridge to Health at Madhousetv.com.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi, welcome back to the Bridge to Health. My name is Dr. Tom Dow, and each week on our show we have a special guest from a different healthcare discipline who works as part of our integrated team to help you, the patient. This week I have the great honor of having a renowned gastroenterologist with us who we've worked with for many, many, many years, Dr. Mehta. Hi, Dr. Mehta.
Yeah, nice to meet you.
Thank you very much for being on our show today.
Thank you for inviting me.
So we're going to explore a lot of different topics today, and we're going to try to explain to the audience exactly what it is a gastroenterologist does, how important it is for them to see a gastroenterologist at certain times in their lives. And so first of all, why don't you just tell me a little bit about what exactly is a gastroenterologist?
Gastroenterologist is a specialist who treats the disease of the GI tract, which involves anywhere from your mouth, you're going to the esophagus, stomach, small intestine, and the colon, as well as diseases of the pancreas and some degree disease of the liver. Excellent.
And so you went to regular medical school, and then you did your residency and specialized in gastroenterology, right?
That's correct.
How long is that residency to be a gastroenterologist?
Well, after medical school, we do 3 years of training residency in internal medicine. Mm-hmm. After the 3 years in internal medicine, we subspecialize in gastroenterology. When I trained, it was a 2-year fellowship program, but now with the expansion in the amount of knowledge, amount of new diseases we've come out with, it's become a 3-year fellowship program. So it's 6 years after your medical school to become a gastroenterologist.
What are some common conditions that you treat on a daily basis or see or diagnose?
Some of the commonest GI or gastrointestinal problems we see and treat on regular basis are number one, gastroesophageal reflux disease, or what people call GERD, described as heartburn. That's one of the commonest gastrointestinal diseases we see. The next common we see is what we call irritable bowel syndrome, called as IBS, known as spastic colon, various names it goes by. The third thing we see is people coming in for their routine colonoscopies, because as you know, colon cancer, second commonest cancer both in males and females, and as general public, everybody is becoming more aware of this disease. More people are coming in to get their screening colonoscopies, and of course if they found something, then they follow up.
Right.
Other common disease we see is what we call inflammatory bowel disease, which under that there are subgroups of what they call Crohn's disease, ulcerative colitis, and there are other types of colitis we also see.
Okay, so let's go back to the first one.
Sure.
Let's talk about acid reflux. That is when a lot of people, they call it agita. Oh my God, I just ate something spicy. I got this burning here. I can't make it go away. And most of the time they take a Tums or they take a Mylanta and antacid. What exactly is happening in people's GI tracts when they feel that?
Very good, yes. Actually, gastroesophageal reflux disease by far is one of the commonest GI, and probably even in general regular practice, one of the more common symptoms patients complain of. On an average, it's been said that 40% of the general public have had episode of at least one episode of what we call reflux disease or angina, heartburn once a week. Some people, and then a fair population more than that, but at least 40% get it once a week. What actually happens, why do people feel this burning, is the gastric contents, of which the most important is your hydrochloric acid, the acid that stomach makes. It comes up above your EG junction, or the junction between the esophagus and the stomach. When it travels up into the esophagus, it causes severe burning.
Why does it come up?
Okay, there are several factors that then cause. Normally, let's look at why doesn't it normally come up. We all make acid in the stomach. It's important in our digestive process.
Right.
Why doesn't normally? Because we have certain what they call protective mechanism, of which the most important one is the LES, which we in medical term we call LES. It's the sphincter or a valve between your esophagus and the stomach.
Is that the pyloric sphincter?
No,
This
is different.
Okay.
This is called esophageal sphincter, which is at the lower end of the esophagus.
That's like a little hole that opens and closes, like a
right.
valve, right?
Exactly.
And normally that would keep the acid in the stomach.
Exactly. The valve actually remains most of the climes closed, and we now have ability to measure the pressures in people who complain of a lot of heartburn. When that pressure is not maintained in between you, it only actually opens up when you eat to let the food go through. Otherwise, normally it remains closed. When for various reasons that valve doesn't work to its capacity is when acid reflux occurs.
What would be some of those reasons that would stay open like that?
Okay, there are some food products that when we consume on regular basis have been known to decrease that.
Wow.
Of that, the common ones actually chocolate and mint has been known to decrease the pressure in that.
Wow.
Certain carbonated drinks, because the carbonation when it enters the stomach increases the stomach pressure, which actually makes that valve not work normally, unable to close completely, and that makes the valve not completely closed and acid reflux occurs.
So it's not that the person is making too much acid, overproduction of hydrochloric acid, it's just that valve is not staying closed, right?
Absolutely correct, yes. It's more of the dysfunction of the valve.
And when they take an antacid like Mylanta or Tums or that type of thing, it's just decreasing the acidity of the acid so they don't feel the burn as much, right?
Exactly. The symptom that occurs most of the time is because of the acid, because as you know, hydrochloric acid is a very strong acid, and your esophagus doesn't have any lining protection against that kind of acid, so it gives you the burn. So when you take an antacid which is alkaline in nature, it right away neutralizes the acid, gives you immediate relief of your symptoms.
Okay, now the most common drug used to treat that condition is what, Nexium?
It's, yes, Prilosec, Nexium, Prevacid, which under all general fall under a term called proton pump inhibitors.
And what do? They don't decrease the acidity. Do they affect the valve?
No, they do not affect the valve. They actually decrease the acidity.
Oh, okay. So it decreases the hydrochloric acid production?
Exactly. Exactly.
How do people still digest food if they don't have the hydrochloric acid?
Very good question. And I actually, some of my well-educated patients do ask me that question. They said, oh, I think hydrochloric acid is important in your digestion, and it absolutely is. You see, acid is produced by pumps in our stomach called proton pumps. When you take this medication like Prilosec, Nexium, Prevacid, it does decrease the production of the acid anywhere from 40 to 50, maximum on higher doses up to 60%. So you're still producing some acid. So you're not cutting down the acid to zero. Your digestive process doesn't completely shut down. To some degree, does it affect some digestive process? It probably does, but not to a significant level that will affect your nutritional absorption or your nutritional condition.
Okay, excellent. Now, a lot of people come to me as a chiropractor, and they say, I have hiatal hernia. What is that?
Okay, very good. Hiatal hernia is also one of the conditions that leads to acid reflux. Hiatal hernia is what happens where a part of the stomach, the upper part of the stomach, migrates up into the chest above your diaphragm. Normally, in a normal anatomy, your esophagus is above the diaphragm. Right at the diaphragm is where you have the junction of the esophagus and the stomach, and that's actually the diaphragm which actually also helps to keep the valve closed. And then you have your stomach. Now, due to certain conditions which we can elaborate further, your part of the stomach migrates up. Once it migrates up, now you think of part of your stomach is sitting up in your chest, and now you lost that valve, because like I said, your diaphragm is mainly acting also help you with the valve. So you lose that valve. Number two, as you know that your chest, every time you breathe, causes a negative pressure. So now when your stomach is in the chest, it's causing a negative pressure, acid is already sitting there, you're going to have more acid reflux.
So basically the hernia is in the diaphragm muscle which goes across your body, and instead of it being this big, it might be opened up more and the stomach comes up through it.
Absolutely correct. Absolutely correct.
Interesting. And how do they treat that? Is there surgery for that, or do they leave it alone? What's the treatment?
Yes, there is surgery, but not everybody with hiatal hernia needs a surgery. There are various levels or types or degrees of hiatal hernia. One of the commonest we see is a mild or very slight sliding hernia, in the sense that the hernia is not present all the time, but under conditions of increased abdominal pressure with a full stomach, when they're doing strenuous activity on a full stomach, at that time your stomach slides up.
Can it get stuck up there and not come back?
In very rare condition it does.
Is that a dangerous condition?
It can become a dangerous condition, again under certain conditions. Thank God for 90% of the time it slides back down when that activity, your pressure in the abdomen is decreased when you stop doing whatever is increasing that pressure.
Wow, very, very interesting. I've heard, not heard, but I've had read a lot of articles actually, which people have heartburn, they have burning in their chest that they think is from something they ate, but it could be indicative of a heart problem too, right?
Absolutely, absolutely.
Have you had patients come into your practice with those symptoms and you work them up and you find out, hey, it's not a stomach problem, go to a cardiologist?
Absolutely. In fact, many a time when patients come to me with this heartburn, but when I take a detailed history and I see they have fair number of cardiac risk factors, before I subject them to any procedures, I tell them to see a cardiologist, because I hate to see any cardiac event occur during an endoscopy or a procedure which I'm doing, because as you know, heart is definitely much more important organ.
Absolutely.
So absolutely, yes.
Absolutely.
And so that's something that, I mean, younger people less of effect. If somebody with 20 years old comes to me with more of this heartburn, right, I would of course think, but if it's somebody older with risk factors, yes.
So I think it'd be, valid to say and important to say to the audience who's listening to us that if you're having chronic heartburn and for a long period of time, just don't dismiss it and say it's heartburn. It might be something more serious, and they should really find out what it really is, right?
Absolutely. I have had quite a few patients who actually ended up getting stents and all their heartburn was cured after a cardiac stent. Absolutely. Wow,
very, very interesting. What is, I've heard a term called Barrett's esophagus. What is that?
Well, yes, Barrett's esophagus is actually a medical term we use when the lining of the lower part of the esophagus changes from its normal, which is a columnar type, to a from a squamous type, to a columnar type, which means it is becoming a precancerous condition. It has been attributed, it occurs secondary to chronic long-term exposure to acid from the stomach. Now there is also new thinking that it's not just the acid, maybe it's the acid and the enzymes and the other gastric contents, maybe a little bit of bile, but definitely acid plays a major role in this transformation of the lining to a precancerous type of lining.
And what do you do once you find that?
Once we find that, number one, the most important thing is we need to aggressively control the acid in the stomach. Like, you know, acid does play a major role, so we put them on this medication we talked about, like Nexium, Prilosec, or Omeprazole, which are proton pump inhibitor. And first, so number one is to control their acid. Number two, since it is a precancerous condition, we do surveillance endoscopies on them and do this biopsies to make sure those changes, because if it's a precancerous doesn't mean everybody will get a cancer. But now we want to survey for those who are going to get cancer. So there are these certain changes that occur in the lining which you can see microscopically. So we do this every 2 to 3 years, do an endoscopy, do biopsies. If there's any changes occurring, then either we treat aggressively or send them for surgical. There are other treatments available, right, radiofrequency ablation to treat that.
Does the esophagus have any digestive function, or is it just a tube that passes the food down into the stomach?
It's purely a tube that passes the food, has no digestive function.
So the lining of the esophagus has no absorption ability. It's not like the lining of the rest of your GI tract, right?
None at all, yes.
Somebody should come out with an invention where they have some type of coating they can coat the esophagus with, you know, spray it in there so in case they have a problem, it's not going to get burnt, right?
That'd be the idea.
Make $1 million.
That's right.
Interesting. Okay, so you have a patient come to you, and they are 50-year-old male. They've never had a colonoscopy before. Is it time for them to have one? Is that the right time? Should they have had it before? What's your views on that?
Okay. It's absolutely. Now, when a 50-year-old gentleman comes to the office, or male, female, doesn't matter, Once you're 50 old, it's definitely indicated by American Cancer Society, Gastrointestinal Society, that you should get what is called a routine screening colonoscopy. Why? Because colon cancer is the second commonest cancer in both sexes, in male and female, and
second most.
Second most
wow.
common. And in both the cases, in all cases of colon cancer, we know all cancers start as a polyp. And a polyp which we can remove at a colonoscopy, during a colonoscopy, has prevented the cancer coming on. So absolutely, when a gentleman or a lady walks into or a patient comes into my office with age of 50, even for another reason, I always mention to them, if you haven't had your screening colonoscopy, it's time to do that. Now you also ask me whether it can be done before age of 50, and there are certain indications where we do them before the age of 50.
Like if they have a family history of colon cancer?
Absolutely, a family history, again a family history where one of their first degree relative has had colon cancer before their age of 60, because we do it 10 years before the youngest member in their family had colon cancer.
Right.
So if they had somebody who had colon cancer in 50, they should actually start getting screened at 40. Gotcha. So it's because the reason for that is, we know from a polyp to cancer is about 7 to 10 years, and the idea is to pick it up at a polyp stage. We don't want to wait to find out I have a cancer, then I didn't do any service to you to go and tell you now you have cancer, get it done. What we like to do is prevent that cancer coming on. Right. So in order for me to prevent, I had to pick it up at a polyp stage, take out the polyp, thereby I have prevented the cancer coming on.
How long is the colon, and what part of the colon do you actually look at when you do a colonoscopy?
Okay. Colon is anywhere from 3 to 5 feet on an average person. When we do a colonoscopy, we go from the rectum, which is the lowest most part, all the way to the cecum, which is the proximal end of the colon, just before the small intestine joins. Also in some cases, and in as many as possible, we also try to look at the distal part of the small intestine, because there are some diseases that are peculiar or limited to that, such as Crohn's ileitis is limited. There is a certain condition called carcinoid, which is a benign tumor, which is often seen in terminal ileum. So, and over the years in my practice, when I have done that, I have picked up a few cases which were totally asymptomatic, meaning they were small size that didn't become, but if they didn't want picked up later in the life, it would have grown and caused them a problem. So we picked up those cases and had those surgeries and saved them some future problems.
On a previous show, we had a radiologist here, and he was telling us about the abdominal CAT scans and 3D CAT scans of the GI tract, and he was telling us that basically it's extremely diagnostic for polyps and cancers and things like that, and it could actually pick them up when they're not in the lumen but actually in the wall sometimes, which a typical colonoscopy, you can't look in the wall, it's just what's in the lumen, right?
Yes.
So do you utilize that technology prior to a colonoscopy, or in addition, or in conjunction with it, or what?
No, now yes, what he probably was telling is, yes, CAT scan we do use. Now let me tell what are the conditions we use CAT scan. One is whenever I diagnose somebody with a mass in the colon suspicious for a cancer, definitely one of the steps we do after that is to get a CAT scan, and this is to rule out whether the tumor has spread into the wall, beyond the walls of the colon.
Right.
But the 3D, what he may be talking about is what we now call virtual colonoscopy. That's the name being given.
That's what it was, yeah.
Now virtual colonoscopy is a 3D where you do CAT scan at a shorter intervals rather than 10 millimeter 5. It's a high resolution, and then the computer creates a 3D image of the colon. It has been good in picking up polyps in some cases, except that depending on the type of machine and the person reading it, there have been problems with, they have not been able to really identify what they're seeing. Is it a piece of stool or is it a true polyp?
Okay.
Now,
so it's not a replacement for a colonoscopy?
No, it's not a replacement. And number two, is that one is purely a diagnostic, meaning if you see something where they're not sure, they're going to send you to a gastroenterologist to get your colonoscopy now.
Right, right.
Now this technique and availability has been out for quite a few years now, at least 5 years plus. The reason it hasn't been picked up and many insurance have not is a couple of reasons. Number one, the most common is you still have to take, most people, when they come to colonoscopy, one thing that the reason people are not coming that as often as they should, or as when they should, is the preparation. Most people fear, oh, I have to take that prep, I'll be running to the bathroom,
right.
I can't go 2 days or a day without eating.
Right.
The thing is, when you go for this virtual colonoscopy, unfortunately you still have to prep.
Same prep?
Because If there is stool in the colon, like I told you, the CAT scan can't differentiate, is that a piece of stool or is there a polyp hiding behind the stool? I don't know.
Right.
The little advantage I have during colonoscopy, even if somebody has not done the prep completely, when I'm looking directly, I can see a stool and I can see a colon, and I can wash when I'm there.
Right.
Through the scope, I can put this jet of water, clean up the stool and look underneath that, which you don't have that ability during a virtual colonoscopy.
Interesting.
And then the patient, when you tell after a virtual you took your prep, but now we see something now, go to it, so you'll have to take the prep a second time before you go. If I'm doing it once, I want to get it done right, do the thing that I can not only get a diagnostic, but if there's something, it's taken care of at the same time. So many people then have preferred. And because of this and because of some of the overread and depending, many insurance are not covering that virtual colonoscopy.
What about this little camera I've heard that you can swallow and it travels all through your GI tract and it can look at everything from the mouth all the way out? What is that about?
Yes, that is called capsule endoscopy, and we do provide that service. It is basically a camera which you swallow. It is continuously takes picture every 2 seconds of your GI tract as it rotates around. It transmits, you wear a portable device on your belt which actually transmits all those images into that device. What you do is, the day before we put you on a liquid diet, you come in the morning, you swallow the pill, and that day you remain on a liquid diet. You go around doing what, about 8 hours later you come back, we take off the device, we hook up in a computer and we look at through whole series of those images.
Wow.
Now we do that under certain conditions. One of the common is when we suspect somebody has Crohn's disease that hasn't been picked up. Crohn's disease is a condition where you get multiple ulcers which can be anywhere in your GI tract, from your mouth, stomach.
So is that an autoimmune disease?
It is, we don't really classify, but yes, it can be classified, but it's not a true autoimmune disease.
They treat that with like the biologic drugs, right?
Absolutely.
Humira,
Remicade, Humira, absolutely, right. Yes. So it's a condition. So that is one of the conditions. Number 2 is some people who have had anemia where there's presence of blood in the stool. You've done an endoscopy, you haven't found anything. You've done colonoscopy, you haven't found anything. Then the only way to look at is their small intestine.
Right.
Now before this capsule was available, they used to do what we call GI series, where you had to drink this ton of barium and sit and yes, sit in your radiologist's office for hours where they took X-ray after X-ray. Here you get this capsule, you go about, we get the picture, and we have found in fair amount what they are called the small ulcerations, because they've been taking aspirin, and aspirin not only causes ulcers in the stomach, we have found it to cause ulcers in the small intestine. We see them to have this.
You still use that in your practice?
The capsule endoscopy, yes.
That's so interesting. It reminds me when I was a kid, they had this movie called Fantastic Voyage. Remember the movie
Yes,
where they took
yes.
the submarine, they shrunk it down, they put in a needle and injected it in the person's bloodstream. They were able to see everything that's going on.
Right.
That's pretty cool. That's really cool. So explain to the audience, because I have many patients come to me that say, oh man, I've been delaying getting that colonoscopy done because it probably hurts. Does it hurt?
Not at all, not at all. See, colonoscopy, I know it has got a bad rap due to various reasons, and years ago, before we had this good anesthetic agent, what we call propofol now, I used to do them even before propofol was widely available and used, with what is called Versed and Demerol, which are some. But the problem with that is we were doing the procedure where we used to give the sedation and do the procedure, so we used to little under sedate. You don't want to over sedate.
Right.
And then the reason you get pain during colonoscopy is, in order for us to look inside, we have to insufflate air. You
Right.
think of your colon as a tube which
air.
have to,
You have to blow the
inflate.
person up, yeah.
So it's like you're getting severe gas cramps, and
Right.
that's very painful.
Right.
So, and some of the medication, of course, the problem is if you over sedate, then their breathing becomes a problem, so you don't want to do.
Well, you did mine about a year ago, and it was totally painless. It was, I'm glad I got it done, and thank God everything was okay, but I waited too long like most people do. So I would encourage everyone, if you haven't had a colonoscopy yet, and you're 45, 50 years old, that even if you have no symptoms, you should really go get checked out preventatively. You can prevent yourself a lot of problems. And Dr. Mehta is an integral part of our healthcare team. We use him for consultations in all of our offices, our office in Melville, our office in Ronkonkoma, and Hicksville, because we have patients come in as primary care portals of entry doctors with a multitude of symptoms. They may have back pain, which might be referred from their abdominal tract. So we have to be able to rule out every possibility when you, the patient, comes to our office, and we need to have the team assembled to be able to accurately diagnose what's going on with you and get you the best possible help that's out there. Dr. Mehta, can you tell the audience how they can get in touch with you, or maybe a number they can call if they have further questions, a website?
Sure. My office is located in Riverhead, right on off Route 58. The address is 36 Osprey Avenue in Riverhead. They can certainly call my office. The number is area code 631-727-4171. They can go to Eastern Long Island GI Doctor.com. That's the website, and certainly we'll be more than happy to help you with any questions you have as far as your GI tract is concerned.
Thank you very much, Dr. Mehta, and thank you for being my guest today.
Thank you. My pleasure.
And we're definitely going to have you back on the next show.
Thank you.
Thanks very much. And for those of you watching us on Madhouse TV, stay tuned. We'll be right back. For those of you watching us on Cablevision, we'll see you next time. And remember one thing, if what you want is real wealth, join us next time on The Bridge to Health.
Walker of the New York Jets, former All-Pro wide receiver. You're watching Bridge to Health at Madhousetv.com.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi again. Welcome back to the Bridge to Health. My name's Dr. Tom Dow. And each week we have a special guest from a different healthcare discipline who is part of our healthcare team to help you, the patient, get the best possible care there is out there. in all of our office locations, if we don't have the specialist in-house, we have relationships with specialists, outside of our facilities that we can pick the phone up with. We can stop by their office. We can consult with them to try to find out what is going on with the patient, make an accurate diagnosis, and get either the best care or combinations of care that help the patient. My guest today, again, welcome back, Dr. Mehta.
Thank you.
Thanks for coming back. Our first show, I think, was awesome, and we had a lot of interesting topics covered. We still have so much more to cover. You're a gastroenterologist, correct?
That's correct.
Okay. And you treat diseases and conditions of the GI tract, from the mouth all the way down to the rectum, correct?
That's correct,
Okay.
absolutely.
So we covered some topics on the last show. Now I'd like to cover some different ones.
Sure.
Oh my God, I got agita. My boss is bugging me. My stress with my coworkers. It's giving me ulcers. Oh my God, I'm going to get ulcers and die of ulcers. Do people really get ulcers from stress?
Yeah, I mean, technically, yes, you can, and it's not that it's a direct relation like the stress causes ulcer, but the reason is when you are under stress, your body produces certain hormones. These hormones actually make your stomach make more acid than normal. In addition, when you're under stress, your eating changes. As you know, you probably don't eat on time, you don't eat the right stuff, you're always eating on the go, whatever's available. Spicy food, citrus fruit, it's food that are not good for your stomach.
Right.
You may go long hours without eating, whereby now stomach acid is sitting in your stomach. Then you have a little headache, stress, headache, then you take a little ibuprofen, a little Advil for your headache, and now you have the right recipe to get a stomach ulcer.
What is exactly an ulcer?
Ulcer is where the top lining, at the minimum, at least the top lining of your stomach gets eroded away. And now the acid is in direct contact with your submucosa, which is the lining below the top lining.
So normally the normal lining of the stomach is it protects, the acid can't hurt the normal lining, right?
Absolutely. Your stomach can handle that acid. It has this protective lining which prevents that acid causing any damage to the submucosal lining.
So it makes like a hole or a lesion that acid now can attack the lining underneath.
Absolutely.
And that's the pain, the burning pain people feel, right?
Absolutely.
Okay. So is this caused by an overproduction of acid?
Again, it's not caused by overproduction. Acid is again caused by, when I was in med school and when I took my first class on this GI tract, they explained me in terms of a football. It's your defense and the offense.
Okay.
Your acid is your offense and the lining is your defense. Now what you're doing is, it's a combination where your offense is increased, like you said, when you're under stress, acid production has increased. At the same time, you're taking ibuprofen, you're not eating on right thing, eating the wrong stuff, your defense is going down. So now the combination has led to this right thing, which leads to this ulcer.
Okay. I've heard this theory about antacids. I want to know what your feelings are, if you agree, disagree. Every hormone or enzyme or substance we produce in our body is constantly monitored by our brain. Our brain knows how much acid is in our stomach and knows if it needs more. It sends signals from the brain down to the cells which produce acid. And there's a constant regulation of chemicals and enzymes and acids and things in our body. There's a school of thought out there that with ulcers, if you take antacids chronically to buffer the acid that's produced, that the brain gets signals that there's not enough acid in the stomach anymore, so it actually produces more acid. Is that true, false? What do you feel about that?
It has never been proven in randomized any control trial where somebody has studied it. Theoretically, does it make sense to some degree? It probably does. More importantly than that, what I worry somebody using is there may be a more serious problem going on in your stomach, which now you, by taking chronically antacid, you masking that problem till it's
stomach cancer or
exactly,
lesion, something
exactly.
that you're getting rid of the symptoms
Exactly.
that you don't feel because you're putting the burnout of a lesion that might be a problem, right?
Absolutely, and that's I've actually seen some patients come to the hospital who are passing out because they've been bleeding internally from the ulcer, but they have not been feeling the pain because they've been taking chronically antacid to take away the pain portion.
Wow.
And then they come in with their blood count, which is the hemoglobin, down to 5. They're passing out because they've let the ulcer bleed but they've been taking these antacids.
Wow. So they feel burning, they take the antacids, they don't feel the burning, life goes on, but they continue to bleed, they don't even know it.
Yep, exactly, because they're not really treating the problem.
Wow. Okay, here we go. H. pylori. Let's talk about H. pylori. What is H. pylori, and can that cause ulcers? Does it cause ulcers? What is that?
Exactly, absolutely, and this is the right time to talk about H. pylori when you talk about ulcers. Nowadays in GI field, you do not talk about ulcer without not talking about H. pylori. H. pylori is, the organism was discovered more than 20 years ago, but has done a lot. Is we have found out it is one of the main culprit in causing ulcers.
That's a bacteria?
It's a bacteria. It's a fairly resistant bacteria, and understandably so, because it's surviving in your stomach acid. So that bacteria is quite resilient.
To survive that kind of acidity, it's got to be, yeah.
Right. Now, there's studies show that about almost 100% of ulcers in your duodenum, which is the early part of your small intestine, about 80% of the ulcers in the stomach are due to or somehow connected to H. pylori.
80%?
Yeah, up to 80% of the, and almost 100% of duodenal ulcers almost always have some degree of H. pylori.
So it's the real stress is the stress of having H. pylori.
That's that, yeah.
Right?
Yes.
And how do you treat that?
H. pylori is treated with antibiotics. Like I said, because it's a resilient, it actually requires at least 2 to 3 combination of antibiotics to treat it, and it's antibiotics for minimum of 2 weeks. Although now there are newer therapies with stronger and higher dose, you can get away with a 1-week treatment.
Oral antibiotics or IV?
Yes, all oral antibiotics. And
so what's the success rate of treating that without those antibiotics?
I would say it's close to 95 to 99%. We see very few cases where we are not able to get rid of them with regular traditional antibiotics, and we have to go with a higher dose, different combination of antibiotics.
Wow. So years ago, before we knew about H. pylori, how was this treated?
We just used to give medication as needed, and that's the reason. What led to is there was a group of people which you treat the ulcer with the traditional medication, they felt better. 6 months, a year later, the ulcers are back. You again treat, and we are finding, why is this ulcer keep on coming back? The person has been following other factors which we tell them not to do. So then a group in Australia, if I'm not mistaken, did some cultures and found out that it's the bacteria, and once you get rid of the bacteria, the ulcer didn't come back.
Wow, that's very great news and very encouraging.
Right.
So for those of you out there who for years have been told you have ulcers, if you haven't been tested for H. pylori, you should definitely get tested. Might be a 2-week antibiotic trial which will take care of your whole problem. Am I right?
And yes, absolutely. But more importantly now also stomach cancer has been associated with H. pylori. Yes, absolutely. And there is a special type of stomach cancer, what we call, it's a lymphoma type, what we call MALT, M-A-L-T, which is a mucosa associated lymph tissue, and that is just specifically caused by H. pylori. And this kind of cancer in early stages, we picked up and treated with antibiotics. It's treated.
You can avoid the cancer.
Absolutely. Absolutely.
Amazing.
Absolutely.
Amazing. Amazing. So that is a type of bad bacteria. We don't want that type of bacteria.
Absolutely not.
But there are also good bacteria, correct?
That is correct.
What are the good bacteria, and what do they do to help our GI tract?
Okay, these good bacteria are in your colon. Now see, every place or everything has a right place to be in. Now H. pylori doesn't belong in the stomach. When it gets there, it causes problem. Whereas you have this different bacteria, lactobacillus, Saccharomyces boulardii, these are type of normal healthy bacteria which belong in your colon. Actually, they keep your colon healthy. And when there is a deficiency or when you don't have enough of this bacteria, it leads to certain problems. One of the condition is what we call colitis, where what we call C. diff colitis. I'm sure people hear
C.
it.
diff.
Colitis, yes.
C. diff is a big problem right now in our country.
Right. The number one, why do people get C. diff? Because they've been treated with antibiotics for a condition like a respiratory tract, tooth infection, something else, a urinary tract infection. They were given these strong antibiotics. As you know, antibiotics are not selective. They get rid of all bacteria, good, bad, ugly, whatever.
Right.
So when you kill the bacteria and this good bacteria get wiped out of your colon, the C. diff, which is so-called a bad bacteria, we all have some degree of, but our good bacteria keep it under control, because unfortunately, especially in medical field, we get exposed to C. diff, but our healthy bacteria, keep them under check, don't let them flourish. But once the good are gone, like again your protection is gone, the bad take over. And C. diff has been a really bad problem. Recently it's been number of cases, and again now with some they're getting difficult to treat type of C. diff has been.
Well, let's look at what's going on. I mean, the way I explain this to my patients is it's a battlefield. You have the gold soldiers here, and you have the blue ones here. Let's make the gold are the good bacteria and the blue are the bad. As long as there's equal numbers of soldiers, they each keep each other in check, and nothing overcomes anything else. If we wipe out one group of soldiers or we decrease the amount, the other one's going to take over and win the war, whether it's a good war or a bad war, win, right?
Absolutely.
And what's very interesting is we are now at a very critical stage in healthcare where antibiotics have been so overused and overprescribed for many years for routine viral infections, from the time we're children, and for years, I mean, I've spoken to pediatricians, the older ones, not the newer ones today. They're like, oh, I had to give the mother something or they wouldn't have been happy, even though I know it was a virus, to make them feel better. But what that actually ends up doing is, I think you agree, is it makes our antibiotics less powerful long term because these organisms start to develop a resistance against these antibiotics. And now you've got somebody with C. diff who has probably been blasted with antibiotics, which is why you have all this C. diff now, and now you got to find an antibiotic to kill C. diff, right?
Absolutely. Very well put, absolutely. That is a major problem.
Very so I think the lesson that our audience should learn is we should use antibiotics if we absolutely need to, and not just as a Band-Aid to hoping maybe it's a bacteria, right?
Absolutely, absolutely.
So we don't decrease the power of them down the road.
Absolutely.
Interesting article I read today in Newsday, actually, in the Health and Science section. And they just came out with a study which showed that gut bacteria in babies is directly related to the risk of asthma. What they found, and they did a study of 300 children, they found that out of those children that were given antibiotics prior to the age of 1, that what happened was it wiped out the good gut bacteria and it put them at a much higher risk, and they had a much higher incidence of asthma as they got older. So this is really unbelievable how a normal good bacteria in the gut, in the GI tract, can affect the lungs, a totally different part of the body, in the life of a developing baby.
Absolutely, yes. Very interesting. Very interesting.
So this isn't just, the GI tract isn't just worrying about the GI tract. That GI tract can have ramifications on many other parts of the body. Absolutely. As a result.
Absolutely. If you think of it like besides the skin, your GI tract is the biggest other organ which can allow entry from outside antigens, anything to enter your body. And you got to be careful how we keep them in check and balance, otherwise we will end up in trouble.
Doc, what are probiotics?
Now probiotics are this, what they've done is now that we know that our colon has this good bacteria, this protects, so some companies have come up by growing this, manufacturing this good bacteria, sell it in the form of tablets, pills, capsules, where you consume them and it will replenish some of those that you lose either while you're taking antibiotics, your whole immune system dying down. You know, now there are some groups with, you know, with all this food products that have been adulterated with, you know, growing with antibiotics in the feeds and all of that.
That's another big problem.
So with that, I'm sure all of us have depletion of our normal healthy bacteria that we carry is depleting over time when we consume this product. So even if you've not been on antibiotics that you are aware of, you may be consuming it in your food products.
Right. Again, let's make that clear to the audience is we're taking food products, meats, you know, different poultry, beef, where the farmers feed these animals antibiotics to keep them healthy so they don't get sick. We eat the meat and we're ingesting the antibiotics they fed the animals.
Correct.
So, and this is another reason why antibiotics are becoming less effective, because we're eating and taking antibiotics in every day and not even knowing we are.
Absolutely.
Therefore, decreasing the good intestinal flora, the bacteria. So would you say it's a good idea, even if somebody has no symptoms, to take probiotics with what we eat today? Or should we just wait for symptoms to happen?
No, I personally don't think it's a bad idea. To this date, I'm not aware of any person who was taking them and had any side effects. So when you're taking something where we know that there will be benefits and there is no major side effects or no side effects, I think it's a good idea to take.
So you can't take too much probiotics, right, and get you sick?
Not really. I mean, only reason you might have to worry is when you are so immunocompromised, we are getting strong levels of chemotherapy.
Oh, okay.
And they are certain, I mean, they are all different manufacturers, but there are some of these probiotics, they really keep those bacteria at a live. I mean, most of them are live, but the amount of live, which these are the probiotics that you're supposed to keep in your refrigerator and at a certain temperature.
Right.
Those probiotics, I would be careful if you are on high dose chemotherapy or for whatever reason you're immunocompromised, then I would check with your doctor, your oncologist, whoever, whether it's safe for you. But otherwise, as a general healthy person, if you want to take, I would say that's not a bad idea. In fact, all my patients, once any of my patients have been diagnosed with C. diff, I tell them from now on, please take a probiotic, and especially if you ever in future need to go on antibiotic, make sure you take a probiotic along with that.
Do they treat C. diff with antibiotics?
Absolutely.
But so that's why they got to be on probiotics, because that's going to wipe out the good bacteria, right?
Correct.
Okay. I'm going to talk now about a topic which is a real pain in the you-know-what. Hemorrhoids.
Yes.
Describe to the audience exactly what a hemorrhoid is and what causes it.
Okay, hemorrhoids is nothing but, you know, we all have blood vessels right around our rectum. In fact, that's where there is what we call connection between your portal system and systemic system comes into place. Now, what happens is this, like any blood vessel in your arms or leg, they are blood vessels that, however, under certain conditions, they become engorged.
Engorged meaning swollen?
Swollen, meaning there's much more blood than is normal in there. It's like very similar to people get varicose veins in the leg. Think of that, but these are now in your rectum.
Right.
When they're in the rectum, they cause few things. When they're dilated, when they become so much engorged, they cause you burning, they cause sometimes itching, discomfort, and of course when you pass a hard piece of stool, you may erode the surface, nick it, and they can start bleeding.
I've heard they're very painful sometimes, right?
Yes. Now the reason you would get pain in a hemorrhoid is when there's a blood clot forms inside there, because
blood clot.
Yes. Because what happens when a blood clot forms, the pressure tremendously increases inside that blood vessel, and that gives you tremendous pain. Almost it brings a strong man to tears.
Tears to your eyes.
Absolutely. And with those conditions, once I have seen how painful it is, you nick that, get the blood clot out, the pain is almost gone. Immediately.
So those veins have a lot of nerve endings in them then?
Absolutely.
Sensory nerve endings.
Because in your rectum you do have normal, because it gives you sensation when you're moving your bowels. So you normally we have a lot of nerve endings because it's required, but now this nerve endings, because of that, it gives you that pain.
And how do you treat those? Can you get rid of them?
First, of course, we like to do prevention is better than cure. So, of course, we like you to prevent getting hemorrhoids. Now, what are the reasons why some people get hemorrhoids? One is sitting long hours on a toilet bowl. You know, people have tendency sometimes read their whole newspaper while sitting on the morning. And if you think of it, you're sitting there, there's nothing holding that pressure up. So, you're sitting there, sometimes straining to your bowel movement, you're increasing the pressure. So, that blood is flowing more in that, more chance of those veins are going to get engorged.
Right.
People who go frequently or not infrequently, they put pressure. People go frequently, they're still straining, going, sitting, wiping. So that all leads to hemorrhoids.
Constipation?
Constipation definitely leads to hemorrhoids. So we like you to have regular bowel movements, not sit long hours on your toilet bowl. Try to not get constipated, take enough. So we suggest some form of fiber therapy, Metamucil, whatever to do that. So of course, first we soften it up. So first we like to prevent. Then comes the treatment part. Treatment depends on the stages or the grades of hemorrhoid. There is one which is minimal. We like to treat it with local cream, anywhere from over-the-counter preparation H to their more stronger prescribed creams, suppositories. That's the second level. Then in grade 2 and 3, we do what is called either you can do laser therapy, you can do injection where you inject those hemorrhoids, sclerose them down just like the veins that people do on the legs.
You inject them with a solution that makes them shrink, right?
Exactly. You can do rubber banding, meaning they bend them off. So you bend them, they tied off, you basically sclerosing them eventually. And then in later stages when they are really big and large, and in those cases where they are externally, then surgery where they go in, excise those hemorrhoids or do hemorrhoidectomy.
Hope I never need you for that one.
Yeah, we hope, sure.
And what is diverticulosis?
Okay, diverticulosis is a fairly common condition, interestingly much more common in the western hemisphere than the eastern hemisphere. It's a condition where the inner lining, basically your mucosa and submucosa, prolapses out of the muscle layer outside. And think of it, if you're looking at it from the inside, when I'm doing a colonoscopy, it looks like a blind pouch. If you look at it from an outside point, it looks like, you know, a bubble on a tire, how you can get a bubble,
Right.
That's how it looks. So it's an outpouching of the part of your colon.
So it's like a bump that
Like
comes
a-
out
yes.
from the lining of the colon.
Correct,
And
absolutely.
is that because the lining of the colon gets weak and it allows it to bulge like that?
Correct. The muscle which is supporting the inner lining has become weak. So this inner lining, because of internal pressure, has made it come
And
outside.
is it usually just one or like many?
Most of the time it's many. It's rarely we see just one. When there's one, there's more.
So I would think that instead of having a colon that's normal where things can flow through nicely, when you have all these bumps and out pockets, it probably obstructs flow. Is that true?
Yep, it does. Not that it obstructs, but things get caught in that pocket.
In between the bumps.
In between, inside that, it's like you think of it as a blind pouch, like a blind pocket.
Got it.
So things can get caught in there.
And that can develop into what?
Then
Inflammation?
Yes, and
infection?
inflammation, and that's when we call diverticulitis.
Got
Okay,
it.
so diverticulosis by itself is about, they say, 2/3 of the people after age of 55 to 60 in the Western Hemisphere have this condition.
Wow,
Yeah,
that's
so
pretty
it's
prevalent.
pretty prevalent. And years ago, if you had asked me 10 years ago, all the doctors used to say, oh, once you have diverticulosis, you can't eat seeds, you can't eat nuts.
Because they're
which-
going to get caught in those pockets, right?
But recent studies have disproved that. Meaning, actually what we found most often gets stuck there is a hard piece of stool.
Ah,
Yeah, because once you're constipated, the hard piece of stool often gets caught there. Stool already has bacteria, it impacts there, it clears the inflammation, and next thing is
so
you
these
getting
people you probably want to keep on a high, on a soft stool type of
Abs-
regimen, right? So nothing
abs-
gets stuck there.
Absolutely, absolutely.
And what are the symptoms a person with that condition might experience?
Now, when you just have diverticulosis, most people don't get anything except rarely they may feel little discomfort when something is stuck there before it's coming out. But when you get diverticulitis, it's a fairly painful condition. Most people with diverticulitis do come to the hospital because they get severe pain, they almost double over, they get fever, they notice they either can't go to the bathroom or having just liquid stools. So that's a condition.
So they get both constipation and diarrhea.
Yeah, because they can't have a solid bowel movement, but when they try to pass just little liquid. And the reason is when you have diverticulitis, your colon is inflamed, so the lumen itself has become narrowed. So only very little liquid stool is able to pass through, and that's what you're trying to.
Do they treat that with drugs also?
Yes, it's treated with most of the time. I mean, you always need antibiotics, but sometimes as a complication of diverticulitis, you can get what is called a perforation, where the inflammation was so bad that there's a hole in your colon. Now,
Oof, that's very dangerous,
yes,
right?
that can lead to, as you know, peritonitis.
Yes, yes.
Unfortunately, when that happens, people end up getting surgery, and in these cases, not only do they get surgery, but they end up getting a temporary bag, what we call a colostomy,
Right.
initially.
So your job as a gastroenterologist is to manage GI problems, diagnose GI problems, and manage them. But if you have a patient that you go in, you do a colonoscopy, you see a cancerous lesion, you'll do a biopsy. If it's cancerous, you'll then refer out to the appropriate specialty, correct?
Absolutely, absolutely,
A surgeon as well as an oncologist to treat that condition.
absolutely,
And then you work with them as a team.
absolutely. Yes, it's all a teamwork.
All
Yes,
teamwork. Very, very good. Well, Doc, once again, I'd like to thank you very much for joining me today. It was extremely interesting, the topics. And we're going to have you back.
My pleasure.
Definitely have you back again in the future.
my pleasure, my pleasure. Thank you very much.
And just tell the audience once again how they can contact you if they have any questions.
Well, I'm located in Riverhead, near Peconic Bay Medical Center. My office address is 36 Osprey Avenue, Riverhead, and my office phone number is 631-727-4171. You can contact my office. Staff will be will be able to help you with whatever you have. Thank you very much.
Thank you very much, Doc.
Thank you.
And for those of you who have seen our show before, we're always there to help you, answer any questions you have at any of our multidiscipline centers located in Melville, Ronkonkoma, and Hicksville to give you, the patient, the best care possible with our team of specialists. For those of you who have not seen our show before, make sure you catch us because we have some very interesting guests each week discussing topics which are very informative, and you really should know all about these things. Once again, thanks again watching The Bridge to Health, and remember, if you want real wealth, join us next time on The Bridge to Health.